it's a bit of a rigged game because the truth is there's no such thing as an only anterior or posterior. Like I already showed, A-lifts, you have to back them up with screws. But I think more as a philosophical construct, are you going to tackle this, position the patient anteriorly or posteriorly? And that's where I'm going to try to look at some of the MIS concepts that have evolved over the last 15, 20 years to treat things posteriorly. So from an MIS perspective, from a posterior perspective, why posterior? Obviously, we can avoid anterior access surgeons, avoid anterior anatomy, and do it all in a single stage. But what can MIS do? Can we do, obviously, to treat deformity, we have to compress, we have to reduce sagittally, we have to coronally reduce, we have to derotate the spine, principles of deformity correction surgery. And of course, we need sacral fixation and things like PSOs or anterior columnar sections to do larger deformities, larger fixed deformities, and things like that. So that having been said, I'm just going to run through very quickly what can be done. And again, when we talk about posterior correction of any deformity, be it fixed or mobile, we talk really about osteotomies, because even if you do a bunch of A-lifts or a bunch of laterals, if you don't do osteotomies and you don't squeeze down or correct or derotate, you're not going to get correction. You're just going to get a very tall spine. So that having been said, it's important to remember the Schwab classifications of osteotomies for different degrees of release and reconstruction as needed to partial fascectomies or you might call split Ponti osteotomies, complete facet resections, partial body resections, and of course, complete VBR or PSO leading into a VBR section. And so I always like to start with a case, but just to talk about simple sagittal and coronal plane deformity. Obviously, we know how to do that with open surgery, but can you do this with minimally invasive screws and techniques? So this is nothing special.